Hello and welcome to today's session. I hope you're all in good health and taking good care of yourself. So today we have come back with yet another important topic for discussion. And today's topic of discussion is nephrotic syndrome. So nephrotic syndrome can be quite easily seen in our pediatric wards, and it's a very important topic. So let us dive into it. So firstly, coming to the definition of nephrotic syndrome. What is nephrotic syndrome? So nephrotic syndrome is characterized by the following points. Firstly, heavy proteinuria, albuminemia, that is serum albumin less than 2.5 grams per deciliter, hyperlipidemia, that is serum cholesterol more than 200 mg per deciliter, and edema. So these are the 4 points which, if present, we call that the child has got nephrotic syndrome. That is heavy proteinuria, which I will be discussing in the later slides. Hypoalbuminemia, that is serum albumin of less than 2.5 grams per deciliter. Hyperlipidemia, that is serum cholesterol of more than 200 mg per deciliter, and edema. So nephrotic range proteinuria, if present, is when the early morning urine protein is 3+ or 4+ on dipstick or boiling test. So these are the symptoms of childhood nephrotic syndrome in a nutshell. That is presence of edema, albuminuria or high levels of albumin in the urine, which is proteinuria, and hyperlipidemia. So what is nephrotic range proteinuria? So nephrotic range proteinuria is present if the early morning urine protein is 3+ or 4+ on dipstick or boiling test, or if the spot protein creatinine ratio of 24-hour collection urine is more than 2 mg per mg, or urine albumin excretion of more than 40 mg per meter square per hour on a timed sample. Now coming to the classification of nephrotic syndrome. So nephrotic syndrome is mainly classified into 3 types. That is primary or idiopathic nephrotic syndrome, which is seen in majority of the cases of childhood nephrotic syndrome. It accounts for almost 80 to 90% of nephrotic syndrome in children. And whereas secondary nephrotic syndrome is is when nephrotic syndrome occurs as a part of some other systemic involvement or some other systemic disease. And others are congenital nephrotic syndrome, which is rarely present. So coming to primary idiopathic nephrotic syndrome, which is seen in majority of the cases, the cause of this is still unclear up to now. And in the recent 10 years, there has been increasing evidence that has suggested that idiopathic nephrotic syndrome results from a primary disorder of T cell function. And this accounts for 90% of the nephrotic syndrome in children, and therefore is mainly discussed in our slides. And next is secondary nephrotic syndrome. Secondary nephrotic syndrome could be because of various causes, which I have discussed in the later slides. So this is mainly because of the presence of some systemic diseases like anaphylactoid purpura or even HSP, systemic lupus erythematosus, or hepatitis B infection, even in cases of HIV infection as well. And congenital nephrotic syndrome is a rare occurrence, usually occurs in the first 3 months of life, and the only treatment for this is renal transplantation. Now coming to secondary nephrotic syndrome. So secondary nephrotic syndrome the causes can be further divided. It could be because of certain drugs, toxics, or allergies, like in case of due to mercury, snake venom, vaccines, penicillamine, heroin, NSAIDs, captopril, etc. What we are more concerned for secondary nephrotic syndrome is because of infections. So usually it could be seen in case of post-streptococcal glomerulonephritis, or in certain cases, or more commonly it is seen associated with hepatitis B virus infection or HIV, or in cases of shunt or reflux nephropathy, leprosy, syphilis, schistosomiasis, and even in case of hydatid disease. And autoimmune or collagen vascular disorders, so autoimmune causes could be because of hypothyroids or Hashimoto's thyroiditis, HSP, and even in more commonly in cases of SLE. Metabolic disease like diabetes mellitus, neoplasms like in case of Hodgkin's disease or carcinoma, renal lung cell carcinoma or neuroblastoma, breast, etc. And genetic disease like in case of Alport syndrome, sickle cell disease, amyloidosis, and congenital nephropathy. Others are cases where nephrotic syndrome might occur secondarily is in case of chronic transplant rejection or congenital nephrosclerosis. So now coming to primary or idiopathic nephrotic syndrome. Idiopathic nephrotic syndrome further or renally or histologically can be divided into two types, that is MCNS or minimal change nephropathy syndrome, or it could also be a non-MCN. And non-MCN is further classified into certain types, which we will see. So firstly, minimal change nephropathy or minimal change nephrotic syndrome, MCNS. MCNS is further the most common cause of idiopathic nephrotic syndrome. First of all, idiopathic nephrotic syndrome is responsible for nephrotic syndrome in 90% of the cases. But the most common cause of idiopathic nephrotic syndrome is because of minimal change nephropathy or MCNS. So why is it called minimal change nephropathy? That is because when we examine a kidney biopsy section under light microscopy, the glomeruli will appear normal. There is absolutely no difference that we can make out. If we check the same section under immunofluorescence, then there might not be any deposition of immune reactants, or occasionally might be. But what is distinguishing and what tells us that it is definitely minimal change nephropathy is this. Under electron microscopy. So the picture under electron microscopy will show us fusion of the food processes of the podocytes. So this is very important. So under electron microscopy, in case of MCNS type of idiopathic nephrotic syndrome, we will see fusion of the food processes of the podocytes. The other 20% are affected by non-MCN. Non-MCN is a worse prognosis kind of nephrotic syndrome. So here, the other types of non-MCN are mesangial proliferative glomerulonephritis, which occurs in about 10% of these cases. Focal segmental glomerulosclerosis in 5%. Focal segmental glomerulosclerosis is even worse prognosis. Membranous nephropathy in 2% of the cases. Membranoproliferative glomerulonephritis is about 1%, and others are rare or crescent glomerulonephritis. So these are the types of non-MCN type of nephrotic syndrome, which usually occurs in about 20% of cases of idiopathic nephrotic syndrome. And non-MCN type of nephrotic syndrome is associated with a much worse prognosis as compared to children who are affected by minimal change nephrotic syndrome. So nephrotic syndrome, epidemiology, it is 15 times more common in children than in case of adults. And most cases of primary nephrotic syndrome in children are because of minimal change disease. The age at onset also varies with the type of nephrotic syndrome. So now coming to the pathophysiology of nephrotic syndrome. So basically, first of all, before this slide, one second, I would go to the, yeah. So here, basically at the glomerular level, or when the filtration of the fluid takes place or the plasma takes place, so the filtration barrier there is formed by the glomerular membrane. This filtration barrier mainly comprises of three parts. That is the glomerular capillary wall and the endothelium of that capillary wall. The glomerular basement, so this is the capillary wall. This is the capillary endothelium. Then next layer is the glomerular basement membrane, and associated with glomerular basement membrane are the visceral epithelial cells or the podocytes. And the food process of the podocytes is a very important part in the pathophysiology of this entire nephrotic syndrome. So this glomerular basement membrane or this filtration barrier acts as the size and charge barrier through which the plasma filtrate has to pass. Okay, so when we have this glomerular, when there is a damage, the entire pathophysiology of nephrotic syndrome starts or begins from the damage to the glomerular basement membrane, or the damage to the filtration barrier. So when there is glomerular damage, there is increased permeability to proteins, and therefore there will be loss of protein or proteinuria, which occurs at more than 3.5 grams per 24 hours. Because of this, in the body, there is going to be hypoproteinemia. And this hypoproteinemia is going to cause decreased plasma oncoctic pressure. And in physiology, we have learned that plasma oncoctic pressure is responsible for keeping the fluid in the capillaries. So when this POP or oncoctic pressure decreases, all the fluid leaks from the capillary, as a result of which there is edema. And because of this loss of proteins, there will also be a compensatory emergency synthesis of proteins by the liver, as a result of which there will be hyperlipidemia. Okay. So this is what I want to explain. This is the normal glomerular barrier. And the normal glomerular barrier consists of the glomerular basement membrane. So this side is the capillary side. This is the capillary endothelium. Okay. This is the capillary endothelium. This is the glomerular basement membrane, and adjacent or adjacent to it is the podocytes. Now, when there is effacement or fusion of the podocytes, that is one damage that occurs. Secondly, there is in the damaged glomerular barrier, what happens is, so first of all, the podocytes are damaged. The foot process of these podocytes become completely flattened, and there is effacement of the podocytes. Apart from that, the endothelial charge normally is negative. And as the proteins are also negatively charged, this negative charge of the endothelium is going to repel the protein, as a result of which protein is not filtered out and it is retained by the body. Okay. But when there is damage to the glomerular basement membrane, this endothelial charge is also hampered, and there is decreased negative ions. So as there is decreased negative ions, the albumin will also easily cross through this damaged barrier. And fenestrated endothelium, effacement of podocytes, and the loss of the negative charge. These are the three main effects that completely damage the glomerular basement membrane, as a result of which protein or albumin is easily filtered and it crosses the barrier. Okay. So coming back to this slide now. So basically, in the pathophysiology of nephrotic syndrome, first of all, there is structural and physiochemical alteration in the entire glomerular capillary wall. So what are these changes? I will repeat once again. Firstly, there is in the capillary side, the endothelial charge has become negative. There is fenestrated endothelium of the capillary wall. Because of the negative charge, because the negative charge has decreased, the protein, which is also negative in charge, which was earlier being repelled by the capillary negative charge, can now easily cross through the fenestrated endothelium. Also, on the other side, the podocytes, which are supposed to control proteinuria, there is an effacement of the foot process of the podocytes, as a result of which that barrier is also damaged, and resulting from these three damages, the protein can easily cross through the filtration barrier. Okay. So structural and physiochemical alteration in the glomerular capillary wall, that leads to permeability to plasma proteins, and as a result of which there are heavy protein losses in the urine. There is heavy proteinuria, because of which in the body there is decreased serum albumin. This decreased serum albumin will lead to hypoalbuminemia. Hypoalbuminemia will lead to decreased colloid oncoctic pressure. This decreased colloid oncoctic pressure is going to have two effects. One is fluid accumulation in the interstitial tissue, as a result of which there will be edema. And because of decreased colloid oncoctic pressure, there will be, and all the fluid leaking into the interstitial spaces, there is going to be a hypovolemia or decrease in the plasma volume. This will lead to decrease in GFR. And whenever there is a decrease in GFR, there is activation of the renin-angiotensin-aldosterone system, and that RAS system will lead to an increased aldosterone secretion. The end result of which is sodium and water retention, and that sodium and water retention is going to further add on to the edema. Also, because there is so much of proteinuria, so much of loss of albumin, and we know that albumin is synthesized in the liver is going to go for a compensatory oversynthesis, and because of that, there is going to be increased amounts of lipoproteins, and it does try to increase the albumin production, but fails to compensate till the normal levels. Also, side by side, there is an increase in the lipoprotein, but this one word is wrong. There is decreased catabolism of the lipoprotein. There is increased production, but there is decreased catabolism, as a result of which it leads to hyperlipidemia. There is decreased catabolism, not increased. Increased production of lipoprotein, but decreased catabolism, leading to hyperlipidemia. This hyperlipidemia leaks through glomerular capillary wall, as a result of which there is lipiduria. Okay. So now coming to the pathophysiology, basically we have to remember that the main trigger or the primary mechanism in the entire pathogenesis of nephrotic syndrome and fundamental and highly important change is proteinuria. It is the proteinuria which is leading to lipiduria, which is leading to hyperlipidemia, and which is leading to edema and hypovolemia. So the main problem is the damage of the glomerular basement membrane, leading to proteinuria. So the pathogenesis of proteinuria is because of increased glomerular permeability for proteins due to loss of negatively charged glycoprotein. So now we can also classify this degree of proteinuria. So degree of proteinuria, normal protein excretion that occurs as physiology or normal physiological protein excretion has to be less than 4 mg per meter square per hour. Abnormal is when it is between 4 to 40 mg per meter square per hour. And nephrotic range proteinuria, as we have also seen in our first slide, is defined as more than 40 mg per meter square per hour. Now coming to the type of proteinuria. So it could either be a selective type of proteinuria or non-selective. What do we mean by that? Selective proteinuria is where proteins of low molecular weight like albumin, transferrin are excreted more readily. So it is selecting only the low molecular weight ones, and that protein is rather excreted. Whereas non-selective is when both low molecular weight and high molecular weight are lost in urine. Example of high molecular weight proteins is globulin, IgG. Now coming to the clinical manifestations. So basically in minimal change nephrotic syndrome, the male preponderance is double. So it is more commonly seen in males. And the main manifestations, of course, is going to be edema. There is going to be anasarca actually, and generalized edema is the most common symptom that the child presents with, along with decreased urine output. So where decreased urine output and edema will in a child side by side goes for nephrotic syndrome as the first cause. So it could be local edema, that is edema in face or periorbital swelling and in lower extremities. And it could also be generalized edema or anasarca, that is even the penis and scrotum can be involved in edema. Now coming to non-specific symptoms, these are fatigue and lethargy. There could be loss of appetite, nausea and vomiting, abdominal pain and diarrhea can be there. The body weight increases because of the edema, urine output decreases, and in advanced cases, there could even be pleural effusion and respiratory distress. So this is the summary of primary renal diseases that manifests as idiopathic nephrotic syndrome. Basically, what I mean to say is this chart This has been taken from Nelson. It shows nephrotic syndrome, both minimal change, which is this, and these four are the types, as we have studied, is your non-MCN type of nephrotic syndrome. So I would just like to highlight a few points here. Minimal change nephrotic syndrome, which we most commonly see, is seen in case of preschool children. The age is 2 to 6 years old, whereas these other types are seen in school-going children or older children. Sex is more common in males. Clinical manifestations, nephrotic syndrome, 100%, minimal change. Asymptomatic proteinuria, 0. Now, hematuria may or may not be present in case of minimal change. It's less common in minimal change, whereas hematuria, microscopic or gross, both, anything, is much more common. It's around 60 to 80% in case of non-MCN cases. Okay, it's almost around 80% in case of membranoproliferative type of glomerulonephritis, MPGN. Then coming to hypertension, the incidence of hypertension is also lesser in MCNS as compared to the others. Okay, 35%. And the rate of progression to renal failure, so end-stage renal disease or grave prognosis, is much lesser in case of minimal change nephrotic syndrome. MCNS is a good prognosis type of nephrotic syndrome. It rarely progresses to your renal failure, whereas we can see that all of these have got a specific time period in which they can progress to renal failure. Okay. Usually MCNS is isolated and it's not associated with other grave conditions or other systemic conditions, whereas the non-MCN type of nephrotic syndromes are usually associated with HIV, reflux nephropathy, or these are mainly the secondary types of nephrotic syndrome as well. Okay. Then genetics, usually none except in congenital nephrotic syndrome. However, NPHS is a type of gene that might be present. Then in case of focal or other types of non-MCN nephrotic syndrome, in case of focal itself, there is podocin alpha-actinin. The other types do not have any genetic predisposition. Sorry. In case of laboratory findings, we see that manifestations of nephrotic syndrome will be present, but with that, in certain cases, there will be increased blood urea nitrogen as well. However, there is normal complement levels, but in MPGN types, hypocomplementemia can be there. And renal pathology. Of course, in MCNS, we know that there is going to be normal light microscopy, negative immunofluorescence, that is negative for any complement or any other deposits, whereas electron microscopy will show effacement or fusion of the food processes of podocytes. However, in non-MCN type of nephrotic syndrome, light microscopy and immunofluorescence are going to show very specific type of findings, like focal sclerotic lesions in FSGS, thickened GBN spikes in MPGN, membranous nephropathy. And remission achieved after 8 weeks of, yes, this is very important. So progression to renal failure, we saw that MCN doesn't progress. Good prognosis there. Also with treatment, the regression or the remission of minimal change nephrotic syndrome is up to 90%, whereas it's extremely poor or rather resistant in case of non-MCN type. It does not respond to our steroid therapy properly. So these are the clinical features where there will be periorbital edema or facial edema. Along with that, anasarca might be present. There could be pleural effusion as well, ascites, and scrotal edema can be present. Then white hands in fingernails. Also, there will be hypertension. ESR will increase. Then hypocomplementemia might be present. Blood tests, hypoproteinemia might be present. Okay. So this is the typical picture of nephrotic syndrome kids around 2 to 6 years of age. This is an older child, but this is 2 to 6 years of age, lot of periorbital edema, entire face is puffed up. There's facial edema. With that, there is anasarca as well. Pedal edema is present. So now coming to the investigations. In investigations, the most important investigations are a combination of both urine and blood analysis. So in urine analysis, the defining criteria, that is proteinuria, has to be present, which is if it is 3 to 4 plus, as per the urinary dipstick or on boiling, and it has to be selective proteinuria as well. Then if we are doing 24-hour urine collection for protein, so that's a quantitative test for the amount of protein. It has to be if in the nephrotic range, that is more than 40 mg per meter square per hour for children. Another important test is the protein creatinine ratio, which if more than 2 is diagnostic of nephrotic syndrome. Volume, we look for oliguria. Usually that happens in the stage of edema formation, and microscopically in microscopic hematuria can be seen in 20% cases, and in certain cases large number of hyaline cast and red cells might be present. Next, coming to the blood investigations. In blood, we are looking for hypoalbuminemia as well as hyperlipidemia. So serum protein is going to decrease, that is first of all less than 5.5, as well as the albumin is going to decrease less than 2.5 grams per deciliter. There will be hyperlipidemia, so the serum cholesterol and triglycerides, cholesterol will be more than 200 mg per deciliter. And ESR also increases. It is more than 100 mm per hour during the active phase. Serum complement usually varies. In case of minimal change, the complement might not be affected, but in certain cases it might be. And the other thing is the renal function tests, because blood urea nitrogen in around 15 to 20% cases can be raised. Also, we have to look for the creatinine. And additional tests that we need to do, which are very important and which are moreover pointing towards the secondary causes of nephrotic syndrome. Firstly, C3 and anti-streptolysin O titer. This is in order to look for PSGN or glomerulonephritis as well. Then tuberculin test in order to see if the child is also affected with TB, tuberculin, Monto test. And along with that, the chest X-ray to see if there is pneumonia as well as features of tuberculosis. Because if that is so, if a child is having a positive manto without any other features of tuberculosis, even then a 6-month isoniazid prophylaxis has to be given to the child. And if at all the child has got both Monto test positive as well as features of tuberculosis, then immediately our treatment also, the TB treatment also has to be started. And so for that we have to do the chest X-ray. Next we have to do is HBsAg, because HBsAg or HBV infection is quite commonly associated with nephrotic syndrome in children. HIV test has to be done. Then anti-nuclear antibodies is mainly for the autoimmune causes like SLE. And even we have to rule out HSP. Then other thing is urine culture, if at all UTI has been suspected. So now coming to the treatment, because treatment is very important here. And also in case of MCNS, if treatment can give good prognosis as well. So in case of initial episode, this is a very important line, and we have to remember this throughout, that adequate and appropriate treatment of the initial episode is an important determinant of the long-term course of the disease. It defines or it determines how whether the child is going to prolapse or not, relapse or not, and how sensitive the child is going to be to the treatment. So coming to the treatment of the initial episode, this is the most important, and keep in mind that this has to be followed up very thoroughly with the child and the parents. So standard medication for initial episode treatment is steroids, prednisolone or prednisone. dexamethasone, methylprednisolone, betamethasone, nothing else has actually been proved as efficient and is not used as well. It is prednisolone or prednisone. So the total duration of regimen is 12 weeks for minimum. And in initial episode, we give prednisolone at a dose of 2 mg per kg per day, where a maximum dose of 60 mg can be given. But usually 2 mg per kg per day is given for 6 weeks in single or divided doses. And after those completing those 6 weeks, it is followed by 1.5 mg per kg with to a maximum of 40 mg in a day as a single morning dose on alternate days for the next 6 weeks. So 2 mg per kg per day daily for 6 weeks, followed by 1.5 mg per kg as a single morning dose on alternate days for the next 6 weeks. Now, according to, and then the therapy is discontinued. In certain studies, it has been said that the steroid tapering, if done extremely gradually and extremely slowly, has shown benefits, whereas in certain cases or certain studies, that has not been proved. So in certain studies say that after this alternate day therapy of 6 weeks also, over another 6 weeks or so, it should be even slowly tapered and then stopped in even smaller doses, 25% decrease, 25% decrease, and then stopped. Whereas certain, till now, this is completely written in the textbooks as well. Minimum therapy of 12 weeks for an initial episode. First 6 weeks, daily we give 2 mg per kg per day, prednisolone, and over the next 6 weeks, alternate days, we give 1.5 mg per kg. Steroid is usually administered to the child after a meal because in order to prevent the steroid-induced gastritis. Now coming to, so since next is going to be treatment of relapse, so I would like to share certain important terminologies or definitions related to nephrotic syndrome. So remission. Remission is when urine albumin is nil or trace, or proteinuria is less than 4 mg per meter square per hour. That is normal range proteinuria for 3 consecutive early morning specimens. Relapse is when urine albumin is 3 plus or 4 plus, or there is a proteinuria of more than 40 mg per meter square per hour for 3 consecutive early morning specimens, having been in remission previously. A child who has already achieved remission, that is urine albumin nil or trace previously, that child suddenly starting to have urine albumin 3 plus or 4 plus for 3 consecutive morning samples. Then coming to frequent relapses. Frequent relapses is when 2 or more relapses have occurred in initial 6 months or more than 3 relapses in any 12 months. So if first episode has occurred in January, then next 2 or more relapses, if they have occurred within July or in an entire year, there have already been 3 episodes of relapses, then that is known as frequent relapses. Next is steroid dependence and steroid resistance. Steroid dependence means 2 consecutive relapses when on alternate day steroids or within 14 days of its discontinuation. So a child has finished alternate day steroid therapy or 12 weeks of steroid therapy completely, and within 14 days of stopping, if it has recurred, then it is known as steroid dependence nephrotic syndrome. Steroid resistance is when there is absence of remission despite therapy with daily prednisolone at a dose of 2 mg per kg per day for 4 weeks. Now coming to treatment of relapse. So relapse is a very important part of nephrotic syndrome, and therefore treatment of relapse has to be treated properly. So prednisolone is administered at a dose of 2 mg per kg per day, single or in divided doses, until urine protein is trace or nil for 3 consecutive days. Okay. So here in initial episode, whatever we give steroid therapy for 6 weeks as 2 mg per kg. However, in relapse, it's not so. Here, prednisolone is administered at a dose of 2 mg per kg per day in single or divided doses until urine protein is trace or nil for 3 consecutive days. And subsequently, prednisolone after that is given as a single morning dose of 1.5 mg per kg on alternate days for 4 weeks and then discontinued. Usually, for the urine protein to become trace or nil in case of a relapse, it takes up to 2 weeks of time. So this initial daily therapy of 2 mg per kg, it usually takes place up to 2 weeks. And then after that, there is an alternate day therapy for 4 weeks. Therefore, the usual duration of treatment for a relapse is around 5 to 6 weeks. Okay. So basically, in relapse, the urine albumin can start becoming, or the proteinuria can start subsiding. I mean, the child can start going to remission from around 5 days to 2 weeks time. Now, in case the patient is not in remission, despite 2 weeks treatment with daily prednisolone, okay, then the treatment is extended for 2 more weeks. But patients who are showing no remission despite 4 weeks of daily treatment therapy with prednisolone have to be referred for evaluation. Okay. So 2 weeks of daily therapy of prednisolone. If the child is not showing remission, go ahead with 2 more weeks of daily prednisolone therapy, 2 mg per kg per day. But if 4 weeks also there is no remission, in that case, further evaluation has to be done. So frequent relapses and steroid dependence. Following treatment of a relapse with prednisolone, the prednisolone is gradually tapered to maintain the patient in remission on alternate day dose of 0.5 to 0.7 mg per kg. And that is administered again for 9 to 18 months. Okay, so that's what in these frequent relapses, usually in order to once the child has gone into remission, in order to prevent further relapses, the prednisolone is tapered extremely slowly. So even such a small dose, alternate day dose of 0.5 to 0.7 mg per kg, and that is continued for 9 to 18 months and then stopped. Okay, but if the prednisolone threshold to maintain remission is higher than 0.5 mg per kg on alternate days, that is, if you're not maintaining the 0. Or if features of corticosteroid toxicity are seen, additional use of the following immunomodulators is suggested. Okay. Basically, what it means is that we maintain this alternate day dose, and then after 9 to 18 months, we will plan to stop it. But if in order to maintain the remission phase, we have to give steroid therapy more than 0.5 mg per kg on alternate days, that means the child has become steroid dependent, or if features of corticosteroid toxicity are already seen, then instead of steroid or along with the steroid, we have to use certain immunomodulators. So those immunomodulators are basically levamisole, cyclophosphamide, mycophenolate mofetil, and tacrolimus or cyclosporin. Okay, so this tacrolimus and cyclosporin are calcineurin inhibitors. So this is the entire algorithm or nutshell treatment of nephrotic syndrome. So if it is the first episode of nephrotic syndrome and there is absence of hypertension, hematuria, azotemia, so no red flag signs are there. So we will just give prednisolone for 2 mg per kg daily for 6 weeks, followed by 1.5 mg per kg on alternate day for 6 weeks. 12 weeks initial episode therapy. After that, if there are infrequent relapses, in that case, we give prednisolone 2 mg per kg daily until we see remission. That is, urine protein being absent, urine albumin being nil or trace on 3 consecutive morning samples, which usually takes 5 days to around 2 weeks. And then 1.5 mg per kg on alternate days for 4 weeks. This becomes the treatment of the first relapse, that is infrequent relapses. What if it is frequent relapses and steroid dependence? In that case, after maintaining that 9 to 18 month and all the steroid therapy, we refer for evaluation as well, and alternate day prednisolone to maintain the remission. And we have to assess the steroid threshold. Is the child requiring more than 0.5 mg per kg on alternate day therapy? And if there is steroid resistance, then we have to refer for further evaluation with a pediatric nephrologist and also ask for a kidney biopsy. So now, if threshold of less than 0.5 mg per kg on alternate days, in that way, we have to give alternate day prednisolone for 9 to 18 months in order to prevent a next relapse. And if the child is requiring threshold of more than 0.5 mg per kg on alternate days, or there are any features of corticosteroid toxicity, we have to add immunomodulators, and these are levamisole, cyclophosphamide, mycophenolate mofetil, tacrolimus, or cyclosporin. Okay. So apart from this hospital care and steroid medicine care, the next thing that we also have to keep doing side by side is our supportive care. So the child has lost a lot of protein, and with that there is a lot of hyperlipidemia as well. So we have to control all of this through diet. So in the diet, we have to give the child around 2 to 2.5 gram per kg of protein daily. And not more than 30% of the calories should be derived from fat, and saturated fats have to be avoided. And reduction of salt intake. See, nowadays, it is not, we don't tell that the food should not contain any salt at all, but it should not contain any extra salt, like adding salt from above, or sprinkling salt from above, or taking salt on in the side of the meal. That is strictly prohibited. Or other salty things like eating pickles, chips, or other salty snacks or spicy snacks is completely prohibited during this time. Then is edema. Now, for the management of edema, see, basically, when we have started our steroid therapy, it takes around 5 to 6 days for the oliguria to subside and good passage or good volume urine to be passed. So, but however, in certain cases, that the oliguria continues for a longer time, and there might not be, the child might be developing ascites or pleural effusion. In such cases, for edema, specific treatment, that is use of oral furosemide or diuretics, and if required, even albumin is required. So in order to treat edema, we usually use diuretics like oral furosemide, given 1 to 3 mg per kg daily. And in certain cases, we might actually require 20% albumin also to be given IV. And usually albumin infusion is always supplemented along with our diuretics, because albumin can further cause load on the heart during this edema phase and further lead to CCF. As a result of which, albumin always has to be supplemented with diuretics. So it's given at an infusion of 0.5 to 1 gram per kg over 2 to 4 hours, followed by administration of furosemide. So the indications for the use of albumin are if there is severe edema, anasarca. With that, if the child has developed ascites, pleural effusion, genital edema, or there is low serum albumin of less than 1 mg per deciliter. Apart from that, we also have to do patient and parent education. Why? Because nephrotic syndrome is an extremely emotionally traumatic thing, even for the parents. Suddenly the child becoming edematous like that, we will be seeing it in hospitals. We might get used to it. We might know immediately that it is nephrotic syndrome. But just imagine a non-doctor parent suddenly hasta khelta bacha, child is completely all right, and suddenly one fine day, or after just some trivial cold and cough symptoms or some fever, the child has suddenly started swelling, and the parent can do nothing about it. The urine output has stopped, the child has completely swollen up, is completely edematous now, and the parent doesn't know what to do. So we have to counsel the parents, we have to educate the parents about it, we have to because we have to explain the parents that what is the disease. This disease, if requires so and so strict adherence to the treatment, if the treatment is not adhered to, if steroids are not given properly, then the disease, or then nephrotic syndrome can completely relapse. And once it starts relapsing, it might not be good. Otherwise, nephrotic syndrome, if strictly adhered to the treatment, has got very good prognosis. Also, chances of relapse can be there, but usually nephrotic syndrome occurs up to around adolescence, and usually subsides with adulthood. Then the most important thing that we have to explain the patients or the parents is about adherence to the steroid regimen. Because if they are casual and think that okay, the child is all right now, the child is passing urine properly, is playful, is totally active, there is no swelling remaining, there are no signs of the disease at all, so we don't need, why do we need to continue the alternate regimen, why do we need to stick to these medicines, no need, we will stop it, there will be a relapse, and that will be even more difficult. And with each relapse, it is causing some toll on the kidney, as a result of which there can be further difficulties and further complications. And apart from that, because of the drug that is steroid, what are the features of steroid toxicity? What are the features of steroid uh, gastritis? Steroids can also lead to hypertension. So because of that, we might require monitoring of BP even at home. So all such things, all these terminologies have to be very patiently explained to the parents. Usually what we used to do is we used to always make a notebook. In that we used to write the entire history, examination findings, and what treatment was given in detail. That is specifically what day remission was attained, from what day to what day the daily therapy has been given, and from what day to what day alternate therapy has to be given. Then we also ask ask the parents that you have to buy so and so things, so that you can also measure urine output, you can judge if there is protein or not in the urine. And also to take when they are at home, they have to take BP recordings from nearby place or nearby hospital, and also record it in that notebook. Also, because of this steroid being an immunosuppressive therapy, it can lead to various infections, or it makes the children prone to various infections like pneumococcal infections. So what are the various vaccines that have to be taken as a must also needs to be explained to parents. So there is a lot of interaction and lot of education and counseling that we need to do with the parents as well. So this is an extremely important part of supportive care. And other medications, for example, steroid-induced gastritis is quite common. Steroid-induced hypertension is quite common. So as a result of which, antihypertensives or ranitidine and all those other things and other medications have to be told to them. Then immunization. So immunization, because we are therapeutically suppressing the immunity of the child, and as a result of which the child is going to be extremely prone to pneumococcal infections and Hib meningitis, and therefore polyvalent pneumococcal vaccine, if not previously immunized, when the child is in remission and off daily prednisone therapy. And also, one important point is that varicella, if it occurs, or chickenpox, if it occurs in during nephrotic syndrome, uh, or during the immunosuppressant therapy or steroid therapy, takes an even greater toll on the child. It is of a worse, it is of the worst prognosis if it occurs during a nephrotic syndrome. And as a result of which, immediate treatment with IV acyclovir or oral acyclovir, and if possible, even IV immunoglobulin at history of exposure to any other varicella child is extremely important. And if the child has not had varicella ever earlier, or if the child has not had a varicella vaccine, then immunization with a varicella vaccine is extremely important in such children. So now coming to the indications for kidney biopsy at onset, that is, if the age of onset is less than 1 year, nephrotic syndrome less than 1 year, or less than 3 months, that is congenital nephrotic syndrome, is an indication for kidney biopsy. And whenever nephrotic syndrome occurs in less than 1 year, it is of worse prognosis. If there is gross hematuria or persistent microscopic hematuria or low serum C3, this is because these are all features of non-MCN and hence worse prognosis nephrotic syndromes. If there is sustained hypertension, or there is renal failure which is not attributable to hypovolemia, or there is suspected secondary causes of nephrotic syndrome. After initial treatment, that is, if the child is having relapses, if there is proteinuria persisting despite 4 weeks of daily corticosteroid therapy, as we read that if or for all in case of a relapse, the daily therapy has to be given for 2 weeks. If proteinuria has not subsided, or if the child has not entered remission, then 2 more weeks of daily steroid therapy to be given. But if after 4 weeks of daily steroid therapy also proteinuria has not subsided, or the child has not entered remission phase, then we have to go for a nephrologist opinion as well as a kidney biopsy, and also before treatment with cyclosporin A or tacrolimus. So now coming to the indications for referral to a pediatric nephrologist when the onset is below 1 year of age, or there has been family history of nephrotic syndrome. Nephrotic syndrome with hypertension, gross or persistent microscopic hematuria, impaired renal function or extrarenal features. If there are complications like refractory edema, thrombosis, severe infections, and steroid toxicity, or there has been resistance to steroid therapy, or frequently relapsing or steroid-dependent nephrotic syndrome. Now coming to the complications of nephrotic syndrome, since there is long-term immunosuppressant therapy at play here, the first and foremost thing that is a complication is infections. Infection is a major complication. It frequently triggers the relapses also. It's a vicious cycle hence. Nephrotic patients are liable to infection because there is loss of all the immunoglobulins in the urine. There is loss of albumin. There is edema fluid, which acts as the culture medium, use of immunosuppressive agents, and also malnutrition. The most common infections that take place are upper respiratory tract infections, but the most sinister or serious ones are spontaneous bacterial peritonitis, which is mainly caused by Streptococcus pyogenes and your pneumococci, and also E. coli. It can then, other infections are cellulitis, which is again caused by pneumococci. And apart from that, there could be fungal infections as well, and UTI. So spontaneous bacterial peritonitis, cellulitis, and certain vasculitis. Organisms are the encapsulated ones like pneumococci, H. influenzae. In gram-negative, it's E. coli. The next important complication is hypercoagulability or thrombosis. Venous thrombosis is much more common than arterial thrombosis. This mainly occurs because of hypercoagulability of the blood, and hypercoagulability in nephrotic syndrome is caused because of these following factors. That is higher concentration of 1, 2, 5, 7, 8, and 10, mainly our intrinsic pathway factors and fibrinogen. There is a lower level of anticoagulant substance like antithrombin, decreased fibrinolysis, higher blood viscosity, increased platelet aggregation, and over-aggressive diuresis. Also, there could be, in certain cases, acute renal failure, both pre-renal and renal, cardiovascular diseases because of hyperlipidemia, hypovolemic shock because of the edema that has occurred and sudden hypovolemia, and others are mainly because of steroid toxicity like growth retardation, malnutrition, and hypo HPA axis suppression or adrenocortical insufficiency. And lastly, coming to the side effects with long-term use of steroids or the steroid toxicity, that is stunted growth, cataracts, pseudotumor cerebri, psychosis, osteoporosis, Cushingoid features, adrenal gland suppression, hyperglycemia, myopathy, peptic ulcer, poor healing of wound and hence infections and cellulitis, hirsutism, and thromboembolism. So this is all about nephrotic syndrome. So the things about nephrotic syndrome that we need to keep in mind is nephrotic syndrome is defined by 4 things, that is edema, proteinuria, hyperlipidemia, and hypoalbuminemia. Nephrotic range proteinuria. Secondly, the pathophysiology is mainly because of most common in children is minimal change nephrotic syndrome, and it has a better prognosis. This is all because of damage to the capillary walls and the entire glomerular basement membrane, as a result of which there is loss of protein, and this proteinuria is responsible for all the other factors of nephrotic syndrome. The treatment is by steroids. Steroid is the mainstay. In steroids, it is prednisone or prednisolone, which is the mainstay treatment of nephrotic syndrome. The mantra of nephrotic syndrome treatment is strict adherence to the steroid therapy and taking precautions. And initial therapy is 12 weeks. Initial episode therapy is 12 weeks, 6 weeks daily, 6 weeks alternate. Treatment of relapse is daily therapy up till remission, and after that alternate therapy for 4 weeks. The certain things or which we need to do on a clinical basis are, we have to check the height, weight, and the BP of this child at every visit. And also in the first episode also, before we start steroid therapy, we have to check for height, weight, and BP, because with edema, there is a different weight, and once steroid therapy is started, we get the basal actual weight that the child should be. And one more thing is, with the height, we can correlate the child's BP, because in pediatrics or in children, BP is based on children's height and age as per percentiles, and we want to keep the BP less than 90th percentile. Also, the first BP recording at the initial episode is important to see that if nephrotic syndrome has already caused hypertension, or later when if the child has developed hypertension, it means it is a factor of steroid toxicity. And so these 3 things we have to measure at each visit of the baby, and strict adherence to steroid therapy is very important. So I hope with this you study well and take care of yourself. Thank you very much.